everybody for coming. My name is Jen Piotrowski. I'm a critical care nurse in critical care in Woodland Heights. Been here for over 16 years. Yes, I have the pleasure of introducing Dr. Ovadia and working with him for over a year and a half. Yes. So just a little introduction for Dr. Ovadia. His bio. After growing up in New York, Dr. Ovadia graduated from the Accelerated Pre-Med Med program at Pennsylvania State University and Jefferson Medical College, now Sidney Kimmel College, or School of Medicine at Thomas Jefferson University. He then went on to complete a residency in general surgery at the University of Medicine and Dentistry on New Jersey, Robert Wood Johnson Medical School, and a fellowship in cardiothoracic surgery at Tufts New England Medical School. Dr. Ovadia has practiced cardiothoracic surgery in Beaver, Pennsylvania, and Clearwater, Florida. In 2020, he established Ovadia Cardiothoracic Surgery and now works as an independent contractor, cardiothoracic surgeon in various locations throughout the United States. In an effort to overcome his lifelong struggle with obesity, Dr. Ovadia adopted a low-carb, carbohydrate-focused way of eating in 2015. He has maintained a weight loss of nearly 100 pounds, and since March of 2019 has maintained a mostly carnivorous way of eating. He has extensively researched the health benefits of low carb with a focus on heart health through many hours of reading the medical literature, books, and listening to podcasts, as well as personal discussions with many of the physician leaders and citizens scientists involved in the low carb movement. In his recent book, Stay Off My Operating Table, available on Amazon, Dr. Ovadia discusses the principles of optimizing metabolic health to prevent heart disease and other chronic diseases. He also hosts the Stay Off My Operating Table podcast, is a frequent guest on other podcasts focused on metabolic and heart health, and has delivered lectures at conferences focused on metabolic health. Dr. Ovadia has also established Ovadia Heart Health, a telehealth practice that focuses on the prevention and treatment of metabolic and heart disease utilizing lifestyle and dietary modification. He incorporates his hands-on clinical experience with heart disease and the personal insights he has gained in his own struggle with obesity and poor metabolic health. Dr. Ovadia is board certified in cardiothoracic surgery and general surgery. He is a fellow of the American College of Surgeons and is a founder member of the Society of Metabolic Health Practitioners. Dr. Ovadia currently lives in Florida with his wonderful wife and two amazing daughters. So please help me welcome Dr. Philip Ovadia.
Thank you so much for putting this together and inviting me to talk. Really excited to share all of the information that I've learned over the past few years, and really hope to inspire each of you to incorporate this not only into your personal lives but into our practices. And what I really talk about these days is how people can stay off my operating table. And it doesn't only apply to heart disease, as we're going to talk about. The concepts of metabolic health, insulin resistance, are really at the root cause of most of the chronic disease that we spend all of our days and nights taking care of. And the sad reality is that, this hospital, all the hospitals in this country are overwhelmed taking care of sick people right now. And it's not that there's a shortage of us or a shortage of hospitals. There's just too many sick people, and we really need to start addressing that issue. So a little bit about my story. This is me circa 2015 or so, about 100 pounds heavier than I am today. Again, in the operating room every day, taking care of people with advanced heart disease and not recognizing my own struggles, and that I was on my way to end up on my own operating table. I have a family history of heart disease. My grandmother died of heart disease. My dad has had heart surgery. So it is very close to me. And, you know, I did recognize that I was traveling down that same path as so many of the patients travel down. But I, like so many of them, was at a loss of what to do because I was following the advice that I had learned to give. Eat less, move more, eat a low-fat diet, you know, all the things that we've all heard. And it wasn't working for me, it wasn't working for them. And thankfully, you know, I was able to start coming across different information, asking different questions, and, you know, now recognize that there is a way that we can turn all of this around. So, you know, I don't have to explain this to you, you're very familiar with it, but, you know, this is the importance of metabolic health. This is what we deal with every day. You know, these are the plaques that we're cleaning out of people's arteries. This is the fat that is encasing the heart that, you know, we then have to dig through to find the blood vessels to do the bypass. And this is not what it should look like. This is not what we should be dealing with. Again, you know, you're all familiar with this. Heart disease, #1 killer in the United States. 2022 statistics here, over 700,000 deaths due to heart disease, 100,000 more than cancer, way more than, you know, everything after that on the list, including COVID-19. And it's been this way for quite a while, but it wasn't always this way. We go back to 1900, and heart disease is basically undescribed in the United States. We have reports from the leading physicians of the day detailing, you know, what they would see in their careers. And some of these physicians would go their entire career without seeing a case of heart disease. You know, very rare disease. And then we start to see it, you know, increasing in incidence. 1920, 1940, 1950s. 1955, Dwight D. Eisenhower, our president, while he's in office, has a heart attack. Appropriately, this sets off alarm bells, and people start asking, you know, what happened during the past 50 years? Why did heart disease go from nothing to the #1 killer? You know, what's causing heart disease? All sorts of, you know, scientific hypotheses get put forward. Ultimately, the hypothesis that dietary fat, saturated fat in particular in the diet, is the primary contributor to heart disease. And so, you know, the next major thing that happens is 1980. The US dietary guidelines get released. So for the first time in history, the government starts suggesting to people what they should be eating. And the US dietary guidelines have gone through a number of revisions. They actually get updated every 5 years. But, you know, the food pyramid is basically how most people recognize these. And it really hasn't changed all that much since 1980. They've made some tweaks. But, you know, the basis is bread, cereals, rice, and pasta, 6 to 11 servings a day, fruits and vegetables. Minimally, you know, minimal meat, dairy, and they group all fats and oils together and say that these should be consumed in little amounts. And then they further go on to say that any fat and oils that you should be consuming should not be saturated fat. And this is what leads to the whole low-fat movement, all of the stuff that we all remember growing up, you know, the Snackwells and the margarine and the vegetable oil, the canola oil, you know, all become more prominent in our diets. Now, interestingly, when you go to the scientific literature and you ask, you know, what causes heart disease, what are the risk factors for heart disease, you know, you get a little bit of a different picture than we get in our everyday practice. You know, most of us have heard that the primary driver of heart disease is LDL cholesterol. Smoking, of course, is a contributor. You know, other risk factors, things like hypertension, obesity, diabetes, but LDL cholesterol is the primary driver of heart disease. And if we want to have a meaningful impact on heart disease, we need to lower LDL cholesterol. So we can do that through dietary means. That's what the food pyramid was designed to do. We can do it, of course, through medications, statins, first released, 1985, the first statin comes on the market. By 1992, statins are the most widely prescribed class of medications worldwide, and have been for the past 30 plus years now. But if we go back one slide here, what you'll notice is that since 1980 and since 1992, the incidence of heart disease is basically unchanged. We make a little bit of progress from 1980 to about 2010. Since 2010, heart disease has actually been increasing in incidence again, and we're almost back to where we were. This slide cuts off at 2020. We're getting pretty close to our peak levels in 1985 or so there. The main contributor to this decrease, by the way, is probably less smoking. There was a significant drop in smoking, starting in about 1980. So the food pyramid gets introduced, statins get introduced, and heart disease does not go away. So, very large study, updated in 2021. This comes from the Women's Health Initiative. So this study is actually only in women, mostly in nurses, by the way. Started tracking about 30,000 women's health starting in about 1970, and have been tracking it for 30 plus years and looking at all aspects of health, but heart disease has been a big focus of this study. And this study in 2021, what they did was they looked at the women that developed heart disease during the course of the study. They looked at the age that the women developed the heart disease at, and they looked back at the risk factors. So they had their blood work going back 30 years, and they could look back at what the risk factors were. Number one risk factor after 21 years, type 2 diabetes. So having type 2 diabetes versus not having type 2 diabetes increases your risk of developing heart disease over 20 years by 10x, 10 times the risk. Metabolic syndrome, and we're going to talk about that, 6x risk. High blood pressure, obesity, smoking. Everyone thinks smoking is such a major risk factor for heart disease, and it is, but it's only a 4x risk. Family history that we talk so much about, 1.5, almost becoming negligible risk. Now when you look at the blood work specifically, and you say what in the blood work predicted these women developing heart disease, it turns out that insulin resistance, they use a measure called lipoprotein insulin resistance, and again we'll talk a little bit later about what that is, 6.5x risk associated with lipoprotein insulin resistance. Having high triglycerides, 2.15. LDL cholesterol, down here, 1.38. Again, very minimal risk relatively associated with LDL cholesterol versus insulin resistance. 5 times more risk with insulin resistance versus LDL cholesterol. Now just a quick survey. Before a minute ago, how many of you had heard of lipoprotein insulin resistance? How many of you have ever seen it checked on one of your patients in the hospital? None of us, because we don't check it, we don't look at it. It's a basically unknown blood test for the most part, and yet it is a 5 times more a predictor of risk than LDL cholesterol. And every patient seems to get LDL cholesterol checked on like a continual basis these days. This study looked at, this was Norwegian data, and they looked at, is cholesterol a useful predictor of heart disease risk? And basically the answer is no, it's not. So if you look here at total cholesterol levels in men, what you can see is, and these are European units, but the conversion is about 18, so less than 5 millimoles, which is about less than 90 milligrams per deciliter, was their baseline. And as you increase the cholesterol, you do see, a little bit, you see no increase. I'm sorry, 5 millimoles is actually 109, we're looking at total cholesterol here. So 193 milligrams of cholesterol. And what you can see is that the risk of death from all causes actually decreases in both men and women as your cholesterol gets higher. So your risk of death from anything decreases. When you look specifically at cardiovascular disease, you can see there is a very minor decrease. So you go from a risk of 1 to a risk of 0.8 to 0.87. None of these are statistically significant. And same thing in women. That per unit, so per 1 millimole, which is about 20 something milligrams per deciliter of cholesterol, your cardiovascular disease risk goes down slightly, 0.97, but your overall risk of death goes up. The higher your cholesterol, the higher risk of death. And we'll talk a little bit about why that might be. Insulin resistance. So, Gerald Reaven, scientist, physiologist out in Salt Lake City, Utah, did his work 1970s, 1980s, 1990s, and he focused on insulin resistance and coronary heart disease. This is just one of his many studies, but basically they took a group of patients and looked at their insulin levels. So again, not a test that we commonly see done. We see glucose levels checked, we don't see insulin levels checked. But when you check patients' insulin level and you determine if they're insulin resistant, it very strongly correlates with the risk of heart disease. So this is just dividing them up by quartiles: lowest insulin level, lowest incidence of coronary heart disease, highest insulin level, fasting insulin level, highest incidence of disease. And you can do an even better job of figuring out who's at risk for heart disease if you look at whether they are insulin resistant or not. This is a coronary artery calcium scan. So this is calcium in people's coronary arteries. A great screening test for heart disease, very much underutilized. And again, we'll talk a little bit more about that. But this is a great test to show whether or not people are at risk for heart disease. And what we know is the higher your coronary artery calcium score is, the more calcium you have in the arteries of your heart, the more at risk you are of heart disease. The traditional thinking is that once you have calcium in your coronary arteries, that cannot be undone. This is one of my patients that I work with on metabolic health practice. And we actually saw a lowering of his coronary artery calcium score by about 50 points from 300 to 250 over a course of a year, just by changing his diet. Was not on statins, was not lowering his cholesterol, just focused on insulin resistance and metabolic health. So, what is metabolic health? It's a little bit of a tricky concept to explain to people. The simple way that I explain metabolic health to people is when you're metabolically healthy, your body is properly utilizing the inputs that you're giving it. And the primary input that we give our body is the food that we eat. So when we eat, one of three things is supposed to happen to that food. Some of that food gets turned into immediate energy and goes to fuel all of the activities, cellular activities going on in our body. Some of that energy gets broken down into its components and then is used to build and rebuild our tissues, always going on within our bodies as well. And then some of that energy, some of that food gets turned into energy and stored for later use. And on an evolutionary scale, that was very important because for most of our existence as human beings, food was a scarce commodity. We would go times without food, and we needed a way to store energy and be able to use it later. What's happened in our modern food environment is we store all this energy and we never get to use the stored energy. It's a consequence of the foods that we are eating. It's a consequence of our lifestyle. We're kind of constantly eating. And it's a consequence of having high insulin levels. When your insulin level is high, that signals your body not to release energy. So one of the primary purposes of insulin, we all think about it because insulin lowers glucose, but what insulin is really doing is signaling your body to store energy. So it's taking that glucose and it's putting it into storage. We have short storage in the form of glycogen in our liver and in our muscle, and then we have our long storage, which is fat. Glucose gets turned into fat, goes into triglycerides, and gets stored into fat cells. And as long as the insulin level is elevated, your body will not release the energy back out. It will not start breaking down your fat cells. So this is the reason that, we can be walking around morbidly obese, like I was in those pictures, and yet I'm hungry all the time, because it doesn't make sense that I should have been hungry. I was walking around with enough energy to sustain me for the rest of my life. But when your insulin level is high, your body cannot break down that body fat. You can't use that energy. Your sugar levels start dropping, your energy levels start dropping, and your body says, okay, we can't pull it out of our fat. We got to get it outside, get hungry again, and go eat some more. And that's what happens. So from a practical standpoint, how do we evaluate people's metabolic health? 5 basic criteria. Waist circumference, very powerful test that you can do at home, and I do encourage people to do at home. Just take a tape measure, just above the level of your belly button is where you measure this. Do it first thing in the morning. If you're a woman, your goal is to be under 35 inches. Men under 40 inches is considered metabolically healthy. Ideal on this, I tell people, is less than half of your height is really what you want to aim for. But these are the cutoffs for acceptable metabolic health. Blood pressure is our next indicator of metabolic health. High blood pressure is one of the early indicators of insulin resistance and poor metabolic health, and we should start recognizing and then treating it like that instead of just giving medications. 130 over 85 is the World Health criteria for metabolic health purposes, and that needs to be without the use of blood pressure lowering medication. So again, if you've been diagnosed with high blood pressure, if you're on medication for high blood pressure, it's an indicator that you're not metabolically healthy. Fasting blood glucose is our next measure. Less than 100, you can look at the A1C, which you want that to be less than 5.7%. And again, without the use of medications. Type 2 diabetes is one of the defining diseases for metabolic, for poor metabolic health. And then we do look at your cholesterol panel, but we look at the HDL and the triglycerides. LDL cholesterol is not an indicator of metabolic health. Low HDL cholesterol is an indicator of poor metabolic health and a risk factor for heart disease. Less than 40 in men, less than 50 in women is the cutoff. And then your triglycerides, which you want to be less than 150 milligrams per deciliter. Now, again, none of these statistics I think will be shocking to any of us. The rate of obesity, again, 1980, very interesting. US dietary guidelines get introduced in 1980. Our rate of obesity starts skyrocketing, starting in 1980. Metabolic disease in particular. This data is from the NHANES study, again, very large longitudinal study of adults in the United States. This is the 2016 data, published in 2019 or 2020. Only 12% of the adults in the United States met all 5 of those measures of metabolic health. So 88%, 9 out of 10 of us, cannot meet all 5 measures of optimal metabolic health. And you know, one of the things that sometimes people misinterpret is, you know, that obesity and metabolic disease are the same thing. And if you're not obese, you're fine. You're metabolically healthy. Normal weight participants in this data set, only 31% of them were metabolically healthy, could meet all 5 measures. So again, the majority of them were not metabolically healthy. Underweight, which I believe was a BMI less than 20 in this study, still, you know, half of them were not metabolically healthy. Certainly being obese, you know, almost guarantees that you're not metabolically healthy. Less than 1% of obese people are metabolically healthy. But not being obese in no way guarantees that you're metabolically healthy, and that's why you need to screen for it, you know, using those criteria. And that's just pulling out. Now, again, why is metabolic health so important? Yes, it's heart disease, the #1 killer, but metabolic disease has also been linked with cancer, COVID-19, clear data right from the earliest data we had coming out of, you know, China and Italy and New York, the first outbreaks. If you were not metabolically healthy, you were at much higher risk of getting COVID and dying from COVID. Stroke, chronic lower respiratory disease, COPD, Alzheimer's disease, diabetes, influenza, kidney disease, all of these associated with poor metabolic health. And you know, it's 11 on this list because they threw COVID in, but number 10 cause of death most years is suicide. And you might say, well, you know, that can't be related to metabolic health. It is. Very clear data now that mental health and metabolic health are clearly associated with it. Great new book that came out about 6 months ago. I highly recommend Dr. Christopher Palmer, who's a psychiatrist at the Harvard system. His book, Brain Energy. And you know, metabolic health and mental health are essentially the same thing. And he's actually seen great results treating his severe mental health patients, like advanced drug-resistant depression, schizophrenia, bipolar disorder, changes the food that they eat, and they get better. They get off medications and they get better. So what can we do about this? You know, I like to talk about health sovereignty. And personal sovereignty is basically the intrinsic authority and power of an individual to determine his or her own direction and destiny. We are each in control of our health. We can decide what we want to do to improve our health. So everyone should be asking, how can I take control of my health? And for each one of us in this room, we should be asking, how can I help my patients take control of their health? So, you know, think about who influences your health. The government does, family and friends do, hopefully your physician does. You know, the government we already kind of talked about. You know, 1980, they released the US dietary guidelines. Our health has gotten worse by every measure since then. So we need to ask, you know, who is the government really serving? Are they serving us when they give us the guidelines, or are they serving the food industry? And very concerning patterns that we see, you know, with the U.S. Dietary Guideline Committees and the influence of the food industry on the U.S. Dietary Guideline Committee. And the problem is, once the U.S. Dietary Guidelines are in place, that's the food that needs to be served in schools. That's the food that needs to be served in hospitals. You know, we see what our patients get fed, and it's all dictated by the U.S. Dietary Guidelines. Your family and your friends are key influencers on your health. Most people don't realize that obesity has actually been demonstrated to spread throughout populations similar to infectious diseases. So this was a very interesting study published back in 2007. And what they did was they socially and geographically mapped this population. So this actually comes out of the Framingham study that many of you have heard about in relation to heart disease. Framingham, Massachusetts has been, you know, the whole town basically has been tracked with their health for, since 1950 something. And so they mapped the spread of obesity in Framingham, and they looked at social distance between people and its influence on obesity, and geographic distance and the influence on obesity. And basically what they saw was that there was no influence of geography, but there was influence on social connections. So your first degree connections, your friends, your family, if they were obese, you were much more likely to become obese over the course of the study. Interestingly, they broke down the relationships, and the most powerful relationship to determine if you become obese is a mutual friend. So that's someone that you call them a friend and they call you a friend. More influence of same-sex friends than opposite-sex friends, interestingly. The spouse had a relationship, but not as much as your friends. Siblings, on the same line as your spouse. And again, your immediate neighbor, so the geography thing, no relationship. So pick your friends well or start influencing your friends. And then of course, how can your physician influence your health? And I always go back, again, this is not new. The Hippocratic Oath, 4,000 years ago. It says, I will apply dietetic and lifestyle measures to help the sick to my best ability and judgment. I will protect them from harm and injustice. So again, diet and lifestyle, going back to the original physicians. So some principles that I outline in the book, and I talk to people about how you can start making these changes for yourself. The first one, very important, it's kind of the mindset. And what I try and get people to do is reframe your health as a system instead of a goal. When we focus on the short-term goals, if you just say, I want to lose 20 pounds, one of two things happens. You make a bunch of changes, you lose the weight, and you're like, great, I accomplished my goal, and you go back to what you were doing beforehand, and you gain back the weight and more. Or, perhaps more commonly, you don't lose 20 pounds because it's hard, and you get discouraged, and you say, well, I'm just going to go back to what I was doing before because I couldn't meet my goal. Instead, think of your health as a system. If you say, I want to be metabolically healthy, and I'm going to find the habits that support my metabolic health. Much more positive way to think, much more sustainable way to think, going to, keep you going over the long run. Just eat whole real food. I mean, that's really the simple concept that this comes down to. I tell people, eat the things that grow in the ground and eat the things that eat the things that grow in the ground. Animals, plants, that's what we evolved as human beings eating. Most of the stuff that is put forth in front of us as food these days is not food. A friend of mine coined a term that I love. He calls it near food objects, NFOs. And you walk around the supermarket and 90% of it is NFOs. It's not food, it's near food objects. If it comes in a box, you probably shouldn't eat it. If it has an ingredient list, you probably shouldn't be eating it. You should be able to look at your food and know, I'm eating this, and I can tell what's in it, and I've combined these simple ingredients together, and made something. But food shouldn't have ingredient lists. And certainly, those ingredients that are on that list shouldn't be some chemicals that you can't pronounce or don't know what they are. Make one sustainable change at a time. And I think this is important as well. If you try and jump in and change everything at once, again, it gets confusing. Because if it works, you don't know what worked. And if it doesn't work, you don't know what didn't work. So that's why I encourage people to kind of make one change at a time, see what the effect is, and then you can adjust from there. Be more active. So, what we eat is the primary determinant of our health, but activity is a very important component to health as well. And what I want people to understand about activity is it doesn't mean you have to be at the gym. Just find more activity throughout your day. Take the steps instead of the elevator, park a little bit further away, in the parking lot. Just be up and about as much as you can. Unfortunately, again, our jobs are not designed for this. We sit at the desk instead of having a stand-up desk that we can be working at. We just don't move as much throughout the day as we want. If you want to go to the gym, great, but recognize that, if you go to the gym for an hour and you do your cardio, and then you spend the other 23 hours of your day sitting around doing nothing, you're not going to get the effects of that. It doesn't have benefit. So be more active. The other thing I stress about activity is focus on building muscle. Muscle is the most metabolically active tissue that we have. Muscle is metabolically active 24 hours a day, even when you're sleeping. So again, if you're at the gym and you have a limited amount of time, and it's do resistance exercise and build muscle, or do cardio, you're going to get much more benefit from building muscle doing resistance exercise.
I have a question.
Yep.
So recently I had heard about some studies regarding, obviously we know about intermittent fasting,
Mm-hmm.
but this is a 24-hour fasting, and how it actually has been shown to increase your metabolism, metabolic rate,
Yeah.
and you actually get more benefit from going through that whole 24 hours. You build more muscle in that process, say if you do go to work out. How does that kind of factor? Have you seen those particular studies?
Yeah, so there are many different aspects of fast. So in general, fasting I think is a great concept. We need to eat less often than we do, and so that's the starting point. The studies that look at it, the average American consumes calories 9 times a day. Whether you're drinking or eating them 9 times a day. Now do the math. If you get your 8 hours of sleep like you're supposed to, and so you're awake for 16 hours, that means you're consuming calories every hour and a half essentially, to 2 hours. So we definitely need to eat less often. Now my preference is you eat less often because you're hungry less often. If you're trying to force yourself to fast, and especially if you're trying to do extended fast, 24, 36, 48 hours or beyond, and you're hungry, that just doesn't work. Willpower, we all talk about willpower, we're all like, oh, I need more willpower. Willpower does not work. Hunger is a basic survival instinct. You cannot overcome hunger. So the way to get around this is to be hungry less often. And that's what happens when we eat real food. We get hungry less often. Processed food makes us hungry more often. Again, the food industry, they just want to sell us more food. So they want us to be more hungry. They literally employ food scientists who figure out how to make food, more appealing and make us more hungry. The old potato chip commercial, I bet you can't eat just one. Because they knew you can't eat just one. Like, it's literally engineered that food so you can't eat just one. So I'm a big fan of fasting, time-restricted eating, as it's often called, versus extended fasting. It really depends on where you're starting from, what your goals are. Both can be very powerful tools for all of this. And you're right, you can do extended fasting without losing muscle, which again is key. One of the other problems we get into is when we, the traditional approach to dieting, which is just reduce your calories, you tend to lose, as much, if not more, muscle than fat, especially if you're in a high insulin state and you can't get into your fat to even burn it. Your body's going to start burning muscle, turn that protein into glucose. So you got to do it the right way. Make sure you sleep enough. Another key component to metabolic health, and unfortunately, I know our jobs aren't always conducive to that, and our lives aren't conducive to that. But sleep is very important. Stress is another big factor in metabolic health. And again, I don't tell people that you can eliminate stress, because you can't. We all have stressful lives. You just got to figure out some way of dealing with that stress. So whatever it is, you know, your community, meditation, religion, your family, you know, you just need some way of offloading some of that stress. And then finally, you know, ideally we'd all have a doctor who gets it and understands that. And again, I know how difficult that can be. So assess your metabolic health. If you don't know those 5 numbers that I had up before, that's a problem. Figure out where you stand on those 5 numbers. If 3 or more of them are abnormal, you have metabolic syndrome, which means you're headed to all of those diseases that I put up on the top 10 leading causes of disease. If you have 1 or 2 of those abnormal, it's a warning sign, because most people progress to the full metabolic syndrome within 5 years once they develop one of those being abnormal. You can go to my website, by the way, ifixhearts.com. I have a free quiz right on the front page there that goes through those metabolic health metrics. So if you didn't write down the numbers or anything, you can just put in your numbers, and it will tell you whether or not you're metabolically healthy or not. You know, eat whole real food whenever possible, and more throughout your life. And then, you know, define those metrics that you're going to pay attention to for the next 3 months and the next 5 years. And it, you know, weight isn't necessarily the best metric for us to pay attention to. Waist circumference, for instance, much better metric. Figure out what your insulin level is, know what your insulin level is, and you know, work on that. If your doctor won't order these tests for you, which, you know, unfortunately they won't, because it's just not their standard and it's not in the system and this and that, and then they'll tell you, oh, it's so expensive. There's a great website. It's ownyourlabs.com, OWN, There are many others like it as well. You can order your own blood work. A fasting insulin level costs $8. $8 to check it. Your advanced lipid panel, you know, that will give you that lipoprotein insulin resistance score, $47 for that test on ownyourlabs.com. You go to the website, you buy the test you want, you go to LabCorp, and you get the blood work drawn, and you get the results a few days later. So if your doctor won't order it for you, you know, order it yourself, is what I tell people these days. And then just, you know, focus on your way of eating, exercise, stress management, and sleep. And again, eat real food. I tell people prioritize protein, and we way under eat protein. So, you know, the traditional guidelines for protein are 1 gram per kilogram of body weight, which comes out to about 0.4 grams per pound of body weight. In reality, we should be probably eating a minimum of 1 gram per pound of body weight a day. And if you're trying to add muscle, you probably need to eat 1.5 grams of protein per pound of body weight per day. Now think about that. A 150-pound person is going to want to eat between 150 and 225 grams of protein a day. A pound of beef has 100 grams of protein. It's a lot of protein. If you eat that much protein, you're not going to be hungry for the other stuff. You're not going to want the fries with your burger. You're not going to be drinking the soda. You're not going to be having the ice cream afterwards. It's very powerful. If we just prioritize the protein, eat the protein first, that's a very simple measure that can help you, you know, eliminate the other stuff.
What about powder protein as a supplement?
Yeah, it's okay. It's not as ideal. Whey protein is probably the best. There actually is, you can actually get beef protein powders these days. They don't
I was
taste
talking about
like
pea protein.
yeah, I'm not a big fan of the plant proteins, because the problem with plant proteins is that they're incomplete amino acid profile. They don't have all the essential amino acids that we need to build muscle. So, you know, not that they're harmful, It's just that, you know, you don't wanna make that all of your protein.
I just feel
'cause-
like I bloat so much with whey protein that like I have to switch to pre.
Yeah, so if you're dairy sensitive, sometimes that can happen. So pea protein can be an alternative. You can get egg protein powders these days. And then, you know, you also have to look at what else is in that protein powder, because it might be other stuff that's making you bloat. You can actually get pure whey protein powders these days, or you can get them flavored, you know, and they just have a little bit of stevia basically, but they're very clean. And then, like I said, there's actually options now for beef protein powders. Again, that they don't taste like beef, you know, they're unflavored, or you can, you know, they have like chocolate or vanilla flavors or whatever. So those can be a good option if you really can't get, you know, all the protein in by eating it. Animal-based fats. We should be eating, we evolved as human beings eating animal-based fats. We did not evolve eating vegetable and seed oils. They're processed, manufactured, chemical garbage that our bodies don't know what to do with. And again, they have the American Heart Association stamp of approval on them, and they are making our health worse. I didn't overlay the heart disease graph, but if you overlay on the heart disease graph our consumption of vegetable and seed oils, it lines up almost perfectly. And vegetable and seed oils, as much as, you know, I talk about low carb, and I think low carb is a very effective way to do this, it may not actually be the carbs. It's probably more the vegetable and the seed oils and all the processed food. You can't separate the two because all of the processed foods have it. And it's amazing, you know, if you really